compress and we squeeze through the calamity and goes and create a strap on the osteocyte, and it will create this the diffraction of the osteoclast, and we have bone resorption. And in the research on the of the mosquito, when we decrease the oxygen pressure, we will create the bone loss also, because there are the imbalance between the osteoblast activity and osteoclast. So, as we know a long time ago that if we use the light fork, the tooth will begin to move after 2 days. If we use the heavy fork, we will create the undermining resorption, and the teeth will move later. Between the light fork and heavy fork, we have the linear movement. Heavy fork will create the step movement. With the heavy fork, we will have the undermining resorption. That means the resorption comes from here. When we see on the diaphragm, when we use the light fork, we will have the osteoclast working on the PDL space, and we have frontal resorption. If we increase the force, if we apply the heavy fork, what happens? We still have the osteoclast, but it's work another side. They call it undermining resorption, and we have another side. We have higher linearization, and high linearization and undermining resorption. It will stop the movement of the teeth. We look on the table. They show us the optimum force for orthodontic movement. But when we see on the diaphragm of the teeth, what we concern which movement is easier to perform. It's not the optimum force. And when we see on the article, we can see when we apply the fork, we can extrude the teeth around 2 millimeters per month. And another article told us we can extrude the teeth 1 millimeter per week. That means 1 month we can extrude the teeth 4 millimeters. We come back to see on the anatomy of the tooth. You see on the maxilla, we can see the bone house a little bit big, but on the lower, you can see sometimes the house of the bone is very narrow, especially in the lower. Sometimes we can see the palatal cortical bone is very dense and very thick. Sometimes we can see the cortical bone stick together. And with this case, how we can intrude the teeth? It's not easy. With this case, how we can distonize the teeth? It's not easy. When we see on the history of the PDL, when we apply the force with the bone, with the thick cortical bone, we will have the higher linearization. We will have the undermining resorption, and we can see here is the osteoclast. How the teeth move with the cortical bone thick like this. It's impossible. This is one case I showed you with my case. You see, the patient come with me with the protrusive. She asked me to reduce protrusive. I do the extraction for premolar extraction, and the X-ray I do superimposer. On the upper, so okay, so no problem. But for lower, I do the mandible superimposer. You see, I bring the incisor back. The same time, I extrude the teeth. When I magnify the symphysis, what do you see? It's a very thick palatal wall. How the teeth how the teeth green in this case, the teeth green or the bone green. How can I distalize this teeth, the incisor? I distalize incisor by extrude the teeth. So in that case, I don't think it's good reason for. It's not easy to distalize that kind of teeth in the lower teeth. When we put the force on the teeth, in the research of the matter, he told, it's almost impossible to avoid the blood vessel occlusion completely, and consequently it's almost on the case an anoxic situation and local necrosis, no hyaliniation will occur, and this leads to barriers to arrest orthodontic teeth movement that lasts until the hyalinized tissue is completely removed. That means when we apply the force, how we can know there are the hyalinization or not? We only see the tip. We see the ground. We do not know what happened in the bone and in the root. And when we apply the force, if the bone is still there, if the hyalinization still there, how the teeth move? It will move like this. The teeth to come back is much extrude. And if we use the class 1 elastic in straight wide technique, what will happen? It will bring the teeth back and it will bring the molar turn forward. It will happen. And in this kind of the situation, we will see very normal, very common in the clinic. We extract bicuspid, we push the mini screw, and we use class 1 elastic. And when we see with the overbite, we see it's become deeper and deeper. And you see the curve of the speed, you look the curve of speed. In my office, we use a lot of the different technique. The utility, ash, mouth, mill, everything. But the straight wide technique is the basic technique that we use all the time. So when we use class 1 elastic, on more case, when I check on the cephalometric by superimposure, at the same time I will increase a little bit vertical height. This one another case. You see the protrusive case, class 1 low angle biprotrusive, class 2 skeletal. I put the mini screw between the second premolar and the molar. After 7 months, after 11 months, I combine with the utilities, arch, and after 24 months, 28 months, and I debond after 2 years and a half. I look the occlusion before and after. And with the cephalometry, I do the tracing, I superimpose. In the maxilla, I control the vertical, both on the lower. I bring the front teeth back, but at the same time I extrude the teeth. I extrude the molar because I use class 1 elastic. In total phase, we do not see a loss of the increasing of the vertical height. But in cephalometry, you can see better. If we do the elastic, if we use a mini screw, what happens? If we use the mini screws, if we don't control good, if we play the mini screw as far from the incisor, it will be happen. Another case is come with me, 25-year-old man, class 3 case, class 3 dental, and it's a low angle class 3 skeletal. I place and after 2 months, I straight the teeth and I begin to use mini screw at the focus shoe to try to crystallize everything. After 3 months, 4 months, and 6 months, you can see the teeth go to end to end. After 6 months, I get the overset. After 7 months, at the 9 months. In this case, I use a mule wire because I want to extrude the motor also. 9 months, 10 months, and I finish after 10 months. The phase after we had the teeth before and after. Panorama, if you see the space behind of the second molar, it's very narrow. That means I crystallize the molar. I do the self tracing and then extract the tracing, superimpose the manual. What we see, I crystallize the molar, but the incisor, it is the same place. It's only extrude. It's not crystallize anything. Do not crystallize. In the maxilla, I flaring a little bit the incisor and I extrude the molar. So, how can I correct the class 3 case in this case? I increase the vertical. And the vertical, I get only 10 months to increase the vertical, and it helps me to correct the class 3 skeletal. So, compare with another case. If we try to destroy the incisor, we take around 2 years and a half. But when we extrude the teeth, very fast we can get the case. So, class 3K in the mechanism is the mechanism of extrusion. Extrusion does mean it's the easier way we treat the patient. So it's the reason why for the class 3 case, it's not the difficult case. The class 3 case is the easy case because we apply the extrusion. When we see on the teeth, we see the teeth with the teeth and with the PDL around of the teeth. place when we place a force on the teeth, and when we see on the anatomy of the bone, what we see the molar and the canine coppice is placed on the big house of the bone. We see is a very soft bone. That means with the molar and premolar and the cuspid, we can move every direction very easy. But for the incisor is the problem for orthodontic. It's not easy to extrude the molar, lower molar, very easy. Someone you can extrude the molar with a very easy technique. For the upper molar, you see the same. I extrude only. I do not brace the front teeth to show you how we can intrude the molar. It's not difficult. But for incisor, what do you see? The bone very narrow. It's very dense. Sometimes stick together, both cortical, especially Asian patient. How do you correct that? How do you move? How do you intrude? How do you distolize? It's impossible. If you want to do that, it's very difficult. When we play the force on the teeth, you think that this bodily movement? No, it's only the story. When we see on the teeth, we play the force on the teeth, what will happen? The teeth will incline until it touches the stopper. If we still play the force on the teeth will extrude. So when we play, push the mini screw as far of the incisor, that means we cannot control the vertical dimension of the incisor. The incisor is the key of the orthodontic for the easier patient. If we play the mini screw as the extraction side, you see the direction of the force. It will intrude the teeth, the same time is distolize the teeth. But pay attention, if we give the strong force, it still can extract the teeth outside of socket. If one, I will show you my patient. Protrusive, clock one side, clock two, another side. She have one angle of the molar, first molar, low angle by protrusive, class 2K. I remove 3 premolar and 1 first molar. And after 2 months, I place the mini screw on socket on the extraction side. On the upper and the lower, you see the direction of the mini screw. And you see when during the time I distolize the premolar and the cuspid, the over by not change. The over by not change 7 months, 10 months, and 12 months. The over by not change. That means we do not extrude the teeth during the time we bring the bring the premolar and the cuspid back. And after 12 months, after 15 months, I began to visualize the incisor. And after 30 months, I deborn. Before and picture before and after. Patient before and after. And the cephalometry, I tracing. I use a superimpose. In the maxilla, what we see, I visualize the incisor. At the same time, I extrude a little bit because the patient wants to show more teeth when she smiles. I extrude a little bit the molar. In the mandible, you see the incisor. I control incisor. The incisor do not extrude. Another case is a Class 3 case. I propose to do the surgery, but the patient refused. Crowding, Class 3 skeletal. I remove 4 bicuspid and I place the mini screw in the attraction place, and then I distalize 6 incisor. After the face, before and after, and cephalometry, tracing, and superimpose. In the maxilla, I extrude the incisor and the molar a little bit. But on the molar, I control the vertical of the incisor. It extrude a little bit, but not so much. So the position of the mini screw in extraction side help us to control the extrusion of the teeth. Another patient, 15-year-old. When we see, it's a before. It's a class 1 skeletal and class 1 dental. Protrusive, low angle, class 1 bi-ovular protrusive. The number, I remove 4 premolar. Play the mini screw, percussive, and we see from 1 month, 9 months, and 10 months. What happened with the overset? It become deeper and deeper. I had a deep bite. So after 10 months, I decided to change the position of the mini screw. I go to the extraction side. 12 months, 18 months, and after 2 years, you see the I control the over deep bite, and there are small space to close. After 28 months, I want to extrude a little bit the molar. 30 months, and I debond after 36 months. It's very long. You see, inside the mouth before, occlusion before and after. The face, after. The cephalometry, before and after. The number, and tracing. I superimpose the tracing. In the maxilla, you see, I distalize the incisor, extrude a little bit the molar. In the mandible, I control the vertical. I keep the teeth back but not extrude. And when I see on the whole face, what they change. You know, is what happened. The chin go forward. I reduce the protrusive, and the X-ray superimpose. And the face. So when we play the mini screw on the extraction side, will help us to control the vertical. But with the case like this, you see, for the Vietnamese people to control the vertical, to destroy the incisor is always the problem. How we can find out the method, the best method to control the movement of the incisor? We have very good way. This is one of my patients, 28 year old. Crowding, protrusive. How we can control? Plus low angle, plus one by protrusive is the way what we do, what I do. Easier. After 3 hours, I do the ovular setback on both jaw. After surgery 2 months, I begin to bond, to align the teeth and close the small space, and after 6 months, it's finished. It's before and after. Look, I bring on the bone back the same time with the teeth. It's easy way to correct the protrusive. So, the mini screw for extraction side is very simple. And in the mechanic, it will help us to control the incisor in the vertical dimension. And so when we control the vertical dimension, we will get the beautiful face in the motor case, especially when we use the straight wide technique. So alveolar bone structure and density always the factor to consider before deciding to place a force on the teeth. And the first premolar extractive side mini screw are safe, effective to control the extrusion. Thank you for your attention.
Interesting presentation. Now, Dr. Modifichan will